and I go smaller. If my media to media is 4.0, it means that the balloon or the stent I'm putting, it should be 3.5, the max 4.0. It depends on how aggressive you are. Some people will go 4.0, but if you put a 4.0 stent on a 4.0 vessel, just know that the number of ATM don't go too high. If I put a 3.5, I have space to post-dilate, but always equal or smaller. Now let's say I'm not seeing the media for any reason. The reason by IVUS should be shadow. If I get 360 of calcium, I'm not seeing the media, then in that case I go lumen to lumen and I go 0.25 or 0.5 bigger because I don't know how big the vessel is. If I'm cautious, I go 0.25. If I'm more aggressive, I go 0.5. The only time I'm not seeing the media by IVUS is because of calcium. If it's by OCT, it's because of fatty tissue. Fatty tissue, lipid, the light don't go through. So I'm not seeing the media like here, okay? So the most common is media to media, I go smaller or equal. Lumen to lumen, I go slightly bigger. So I know the morphology of my plaque. I know the location of the lesion, I know how big, now how long the stent. I should be landing in normal in the best of the world, but all of you guys are in the medical field, you know that normal is rare. So I land where my, at least the plaque burden where I'm landing should be less than 50%. But again, if you're dealing with a diabetic patient, diffuse the disease, if I get 50% or 55, 60, I'm okay. But if I don't get that, at least where my MLA is decent. I cannot give you a number, but if it's diffuse the disease, I don't want to put stent all over, but if my MLA at one area is, let's say, 4.8 and the rest is 2 point, I'll go to the 4.8. I'll take whatever I have. But according to the rule, it's less than 50% where you're landing plaque burden. If you land in a lot of plaque, the risk of ISR in the future is a lot. So we talk about, this summarize everything, morphology, lipidic, fibrotic, or calcific. We talk about sizing, the diameter, if media to media, I go smaller, lumen to lumen, I go bigger. Length, if I'm landing in less than 50% plaque, if not, I go with the most decent area. Any questions so far? So this is a pre-PCI. Any questions?
How about diffusely diseased vessels?
Yeah.
Should we consider spot stenting versus longer stenting? We should go by physiology ideally, given imaging is the only other additional exercise that we have. How to decide between spot stenting versus?
If, for me at least, if the lesions are too far away, like if I have a lesion here and another here and in between it's okay, I prefer spot stenting. If they are very close and I know that in the lab that I am, I have a decent long stent that can cover both, so I prefer one long stent. But if they are far away and there's decent lumen in between, I prefer spot stenting.
Is the 10 mm is a cutoff, the distance between the two focal lesion? If there is 10 mm distance is adequate, then we can put two small stent. If it is less than 10 mm, then we have to cover
if
the entire.
The gap in between is not that big, usually around 10 millimeters or most 10 millimeters, I do one long stent. I ask them